in regards to vitreoretinal interface and traction and so forth. This doesn't change regardless of whether you have a vascular disease or you have a age-related disease or a idiopathic disease or uveitis. But let's concentrate a little bit on uveitis. These are my financial disclosures, but I guess the most important disclosure here that I have to say is that I seriously cannot practice without an OCT. We used to have a satellite office without an OCT. I never went there. So this is perhaps my most important disclosure at this point. I can certainly practice without an OCT angiogram, but I cannot practice without a structural OCT. Now, when we're looking into an imaging device at this point, the holy grail essentially in uveitis is to find something that can monitor disease, monitor progression of disease, monitor response to therapy, and predict complications and response to therapy. As we heard yesterday by Dr. James, well, especially good uveitis and experienced uveitis specialists can actually recognize disease and diagnose. They don't need a lot of tests. They can actually diagnose through pattern recognition. But even the absolute best specialists in the world, they still need some imaging device in order to actually prognosticate, quantify disease, and actually monitor disease. Now, in the real world, in terms of clinical applications, that's what I'm going to try to emphasize over the next few minutes. We use structural OCT in order to study uveitic macular edema. Well, again, you heard by Dr. Talks, diabetic macular edema from vein occlusions. I mean, does that differ? Well, there are some certain differences in terms of clinical applications and management that I'll try to dissect into. Now, vitreoretinal interface, of course, this is a great tool in order to monitor and study the vitreoretinal interface, and I'll come into some management decisions soon. The neuroretina, we yesterday heard by Dr. Tranos, a great talk in terms of how to actually dissect through the different layers of the retina. Inner retina, middle layers, outer retina, and actually try to get some useful information in terms of prognosis. We're going to hear about, I'm going to talk a little bit, I'm going to touch upon the choroid. There's a lot of interest in terms of actually studying the choroid with structural OCT, and I'm sure Solonas will actually go into further detail, I guess into AMD phenotypes mostly. But I'm going to concentrate a little bit on uveitis, and of course, I'm going to touch upon OCT angiography because just it's a hot topic and I can't really avoid it. Now, this is what I think are very, very important publications in the uveitis literature. It comes from Dr. Marko Michelakis. That is 2004, and of course the images are terrible, as we saw. I mean, what he tried to do, and he was one of the pioneers of doing that, he tried to actually dissect into macular edema and actually try to differentiate between different phenotypes of macular edema in uveitis. Now, as you know, this is a tertiary care center, mixed uveitis population. And what he did is he's tried to distinguish into three different phenotypes: diffuse uveitic macular edema, cystoid macular edema, and serous retinal detachment macular edema, the macular edema that has some serous fluid. The diffuse uveitic macular edema, I would suggest, is this one of these spongy type that Dr. Talks talked about before, this type of diffuse thickening. Now, this was back in 2004, and this was time domain OCT. The images are not that good, but again, as you see, there are three different phenotypes, with the diffuse macular edema being the most prominent. Now, okay, that's useful, an academic distinction, but what do we care? Why do we care about that? Well, when he looked into these patients over the next 3 or 4 years, that's a publication from 2007, what he realized is, and this is a good uveitis specialist, very aggressive in controlling intraocular inflammation, what he saw is that the patients that did not respond to his excellent medical care were patients with diffuse uveitic macular edema and patients with an epiretinal membrane. And contrary to our beliefs back then, now it seems to be intuitive, but it's not. Now, it was not back in 2004. Patients that had subretinal fluid actually did well under medical treatment. Now, again, these are pictures. These are bad pictures from time domain OCT. So this was replicated again and again. This is a paper coming from 2013 using spectral domain OCT. And again, from a mixed tertiary care, mixed uveitis population. And again, in these group of patients, 40% of their patients had subretinal fluid. And that's close to Marco Michelaki's number because in the original paper, there were some mixed cases with subretinal fluid and diffuse edema or cystoid edema. And again, if you look at this, about 40% in his population also had subretinal fluid, which is a lot. Now, we see subretinal fluid in diabetic macular edema. Restored had about 25%. We saw that we see it in the vein occlusions. But again, in uveitis, it seemed to be in a large number. It depends, of course, on the population on the study. Now, all these patients that did have subretinal fluid to begin with, they had lower vision to begin with, and they had higher macular thickness. And what did they do under treatment? Well, as Marco Michelakis showed, they did good. They did well under treatment. At 6 months, they had increased vision, decreased central macular thickness, and even though they started from lower vision, they actually ended up being at vision close to the other subgroups. So subretinal fluid responds to medical therapy. Now we are talking right now about OCT and structural OCT in terms of diagnosing uveitic macular edema, but what about fluorescein angiography? Well, fluorescein angiography was an only tool, and I have to confess that we have been using fluorescein angiography or dye-based angiography less over the last few years. But with one small exception, and this small exception is the uveitis population, because as you can see, and as everybody knows, there's a discrepancy between fluorescein angiography and OCT in terms of macular edema in uveitis. And this cross-sectional study, these are patients from the MUST trial, and this again is time domain OCT, and that's compared to fluorescein angiography. First of all, one useful information is that we had gradable information in 90% of patients with OCT and in 77% of patients with fluorescein angiography. Uveitis patients, as you know, there's a lot of other structural problems. There are media haze, media problems, and so forth. So again, we had more gradable information in the OCT compared to fluorescein. So we have a tool that gives us more useful and gradable information from the very beginning. Now, what about the agreement? The agreement was modest at best with a kappa of 0.44. And if we actually look further into these numbers, about 34% of patients had thickening in the OCT without leakage in the fluorescein, and 40% of patients had no thickening in the OCT and had leakage in fluorescein. And we look. These are very useful and interesting patients, and we'll look further into these patients in the following study that I'm going to show you. So what the author suggested that we need to consider OCT as a first test, which makes absolute sense, and consider fluorescein in order to quantify macular leakage, depending on whether this would alter our management. And again, fluorescein shows us different things. That we have to consider these things as being separate things because it shows us different things. It shows us a breakdown of the blood-ocular barrier, perhaps, in terms of quantifies vascular leakage, quantifies leakage on the optic nerve. Now, in a further study, another cross-sectional study, again looking into comparing fluorescein to OCT, the discrepancies were found in 46% of eyes. About 40% of eyes have discrepancies between the OCT and fluorescein in terms of uveitic macular edema. And again, 15% of them were positive in the OCT, thick OCT without leakage on fluorescein. And these patients were mostly intermediate uveitis patients and were inactive patients. And this is a group of patients which is very interesting. They actually have structural damage. They have thick OCTs, but they don't have leakage in fluorescein. So these perhaps do not have what we call active inflammation, is what we call quiescent uveitic macular edema. And this raises issues about what's our best treatment modality in these patients. And the other group of patients, 30% of them, had no thickening in the OCT, yet they did have leakage in fluorescein. So perhaps they did have some vasculitic activity without real structural damage. And a lot of these patients were interestingly birdshot patients. So again, these are complementary tests. So let's say in age-related macular degeneration, you have the diagnosis from the structural OCT, but in uveitis, you should consider fluorescein angiography because it gives you an additional information which has to do with the general inflammatory activity, and this is important in terms of guiding treatment. So what about the vitreoretinal interface? We just heard an excellent talk about epiretinal membranes. Well, you all know that epiretinal membrane is very common in uveitis. 40% of patients in many case-control studies do have epiretinal membranes, mostly intermediate uveitis and posterior uveitis. Now, in terms of vision, there was a lot of studies trying to find prognostic factors. Well, it seems that the most important factor is the integrity of the outer layers, what we call the ellipsoid zone at this point. It's more important than the actual central macular thickness. And again, what comes again and again in the uveitis studies is that the epiretinal membrane gets thick. There's thicker epiretinal membranes in longer duration of disease. Now, what's common? What's different compared to what you just heard in terms of epiretinal membranes? Well, in uveitis, you might have, again, a very bad scan, yet they seem to be relatively stable as long as you control the underlying inflammation. That comes again and again in the uveitis literature. This is a study coming from USC, from Narsingh Rao's group. And what they saw in a big number of patients, as long as they had inactive inflammation, patients had very, very good course over the years with a relatively stable vision. So again, before you consider peeling epiretinal membranes in uveitis, you should consider, first of all, you have the time to control intraocular inflammation, and perhaps what seems really bad in the scan is not really bad in terms of treatment, especially now with tools as is the intravitreal Ozurdex. Now, again, as vitreoretinal specialists, we really like OCT and structural OCT before we plan surgery. Yes, it does gives us an information in terms of horizontal or anterior-posterior forces. You have to consider, especially in uveitis, epiretinal membrane in uveitis, that again, you would think that there's a very, the proportion of patients that have a complete preoperative posterior vitreous detachment is very high, but that's not really true in the literature. About 50% actually have a complete preoperative posterior vitreous detachment, which means that you have to plan accordingly on your surgical plan. This is a V-shaped VMT with an ERM type of uveitic macular edema, epiretinal membrane in a sarcoid patient that we operated on. These patients usually have a better prognosis. This is a broad VMT, and this is a PVD with a shallow PVD with an epiretinal membrane. So it is a very, very useful tool, obviously, and we cannot really practice without this. But it's not really different to the other, to idiopathic epiretinal membranes and tractions that we just heard. Now, imaging of choroid. The imaging of the choroid is really very, very interesting. Now, obviously, we have better machines. The sensitivity is much better. We have swept source OCTs that perhaps have increased resolution at the depth of the choroid. So we are really moving into imaging the choroid, and you have to recognize that a lot of uveitic entities are real inflammatory choroidopathies or choriocapillaropathies, as they say. And of course, if you have an imaging tool of the choroid, this really does make a lot of sense. Now, in terms of clinical applications, this case series in Adamantiadis patients, even though Adamantiadis patient per se is not, to me, just an inflammatory choroidopathy, yet it has been shown that the thickness, the choroid thickness, is a marker of disease activity, especially in patients upon remission, so it could potentially guide maintenance or not of immunomodulatory treatment. The same is true for VKH. Yesterday we had a discussion, and Paris showed us a very nice patient at the chronic convalescent stage of VKH, where he had some hypofluorescent spots on the ICG, and we didn't really know, should we continue immunomodulation or not? Well, again, it has been shown in this, in multiple studies that the choroid thickness is a good marker of disease activity. When the disease is inactive, the choroid thins. When the disease is active, there's a thicker choroid. And when there's this end stage, atrophic stage of VKH, where you actually probably do not need any immunomodulation, the choroid is very thin, as is in this series again from Narsingh Rao's group. Now, what about OCTA? I should say a couple of things about OCTA. Well, it's a great tool. It has really changed our understanding of disease. But again, in terms of clinical applications or where to alter our management in uveitis, I would probably concentrate on two topics. One is detection and quantification of choroidal neovascularization. It's mostly detection of CNV and distinguishing CNV to an inflammatory choroidal lesion. And the second is, of course, detection and quantification of blood flow in different tissue planes. And this comes again in what we call choriocapillaropathies or diseases of the inner choroid, where you have masking in the conventional dye angiography, and you want to distinguish or you want to quantify the hypoperfusion in terms of the choriocapillaris. So in this patient with PIC, again, you have all the, we have a lot of information from dye-based angiography, but sometimes we're not 100% sure whether there's really active neovascularization or what we see as white inflorescing late is just an inflammatory lesion. So again, if we dissect, again, if we look into these pictures here in the B scans, this is an area where we actually do have blood flow, and this is an area where we actually do not have blood flow. And again, if you look at it with the blood flow signal, it really helps. Now, again, inflammatory lesions do have some blood flow, but it's much less pronounced and doesn't have the pattern that you see in choroidal neovascularization. So again, detection and follow-up and monitoring of CNV helps us in an inflammatory choroidopathy. And again, in other diseases, this is an unexplained, non-diagnosed patient with some kind of inflammatory lesion at the level of the pigment epithelium. You could follow these patients with autofluorescence, but I really found that following these patients with OCT angiography showing the blood flow loss or decreased signal in the deeper layers helps us a lot in terms of monitoring the disease. So with this, I would like to thank you very much for your attention.
Thank you very much, Alex. Again, in the interest of time, we'll hold the questions for the end, and we move to OCT and choroidal assessment. Σόλων Αστεριάδης.
Good morning.